So we have an interesting session with very experienced experts with me to make the complex strabismus simplified. So please feel free to come forward. No questions are being asked. All of you who are on the back benches, you can come forward. ये next हो नहीं रहा यहाँ से. So the topics we'll be talking about today is on what's new in strabismus. So first of all, we are going to have something which is happening, and I recently came from APOS 2023. So there are some trailings from there. We had interesting meeting, and some of you are going to be on both sides, on the picture as well as maybe in the audience here. So recognize yourself. It was a very interesting sessions that we had there with the extroverts there, and after a long time of COVID break, this was a very nicely attended meeting of APOS. Some things are to be remembered always. Strabismus surgery, as we all know now, we have to focus on binocular vision and stereopsis being regained. So that's very important. The goal for us now is to restore stereopsis and not just treat strabismus. And for that, it's important that we treat early. Not only for children, but also in adults. Remember, the timely realignment is important, as studies have shown that if there is a delay of more than a year, binocular vision gets compromised, even in adults. So the recipe in strabismus, as I always say, is observe, confirm, infer, plan, and execute. That is the simplified mode. There are simple procedures. It's very easy to master these procedures. You just need to plan properly. So in the recessions, we had the adjustable recessions. In strengthening, recently we are moving more and more towards plication instead of resection. So that's the new kid on the block. Can you run this? No. Yeah, play this. Can you have my MacBook put there if it's working? So I think now we are using plication not only for the medial rectors, as we talked about in this APOS, we were presenting on DVDs. Now dissociated vertical deviation, as you all know, is a special condition of strabismus, which is many a times creating problems. Phoric DVDs, you don't have to do any surgical management. For intermittent DVDs, optical treatment can be done to make them phoric. But manifest DVDs, as we all know, those which are associated with inferior oblique overaction, the preferred mode is IOAT, inferior oblique anterior positioning, total anterior positioning. With superior oblique overactions, we do superior oblique and superior rectus weakenings. And if there is no oblique overaction, the procedures are either superior rectus weakening or inferior rectus resections. Now, mind you, bilateral DVD with inferior oblique overaction, like these shown you here, now they give very good results by inferior oblique weakening procedures, as you can see here. But also remember that cases in which there is no inferior oblique overaction, and if you do inferior oblique weakening, you will have an A pattern created. So this was operated elsewhere, and this landed with me with an A pattern because inferior oblique weakening was done where it was undue. So be careful. So this study, we compared the cases in which there was no inferior oblique overaction, and there were two modalities. One was IR plication and the other was superior rectus recession with various modifications. Now here there is a picture of 9 gazes of a DVD in the right eye, as you can see here. 10 prism diopters, PVUCT is showing you. And after the IR plication of 5 mm, you can see that it gives us a reasonably good result. Similarly, cases with the DVD which have a similar thing, in which we did superior rectus recession with Y split. Now this is another modification of superior rectus recession of Y split, 5.5 millimeter recession only with a Y split. Now this gives you more yield without giving a Farden procedure or doing larger recessions. And this study we had presented there, and we found that both are good procedures. and suprarectus recession with Y split gives you an additional yield. So these conclusions we can remember for our sake of managing DVDs without inferior oblique overaction. You can use IR plication as a primary procedure instead of suprarectus recession also. And because the reason is it gives you additional benefit of surgical ease, reversibility, minimal intraoperative risks, emphasizing the possible role of this reinvented surgical procedure. On the other hand, when you want to do suprarectus recession, you can add the yield by doing a Y split, which is similar to what you do for Duane's retraction syndrome on the LR. Another procedure which I have found useful recently is for small angle vertical deviations of up to 5 or 10 prisms, then we can do the Kenneth Wright's mini plication. Now here this is a lady who had a 10 prism diopters of left hypertropia, and in this I have done a LIR mini plication. The mini plication is 5 millimeter. From the insertion you pass a suture, but the only difference I do is I do a reinforce. I take another bite after sclera into the muscle, and it can be done very effectively for small deviations. The other presentations that we had was correcting torsions by IOANT. Now you all know that torsions can be a problem in strabismus, and they can be managed very well by oblique muscle surgeries. Cases which have a pure V pattern. Now you see this picture, ortho in primary position, exo in the up gaze, and ezo in the down gaze. So obviously you can't do any horizontal muscle surgeries in such cases because they are ortho in primary position. And you see the inferior obliques are overacting. So if you do a proper inferior oblique weakening procedure, you can correct it in all the 9 gazes. You can correct the inferior oblique overactions as well as the V pattern. Cases which have an asymmetric bilateral inferior oblique overaction have to be treated asymmetrically. So that is another thing to be remembered, and you have to see which one is and how much is the overaction of each eye, and then plan it accordingly. So what we see is inferior oblique overactions come in all shapes and sizes. Sizing is important. So just like you want a proper fit for yourself when you go to the mall, you want a proper sizing, whether it is XS, S, M, L or XL or maybe XLL. So depending on your requirement, you would like to have a sizing done. Fortunately, inferior obliques also allows you to do that. You have various procedures which can give you a graded effect on the surgery. Whether you do a Fink's recession, a Park's recession, a Elliott and Nankin's recession, modified Elliott-Nankin procedure, or anterior nasal transpositioning. So my talk was in this time the EPOS on the Stager's anterior nasal transpositioning procedure, which is a very effective procedure for 3+, 4+ inferior oblique overactions. Now in the recessions, as you know, the inferior oblique is weakened along the course of the inferior oblique. That gives you a pure recession effect. If you advance the insertions towards the inferior rectus like this, it gives you an anterior positioning. But moment you do this, you are also making it a anti-elevator. Why are we saying anti-elevator? Remember, it is not depressor. You can't make inferior oblique a depressor. Inferior oblique will only act when elevation is required. So when elevation is required, and this part of inferior oblique from the neurovascular bundle is the origin, now the functional origin, and the new insertion, this part of the inferior oblique is going to act during elevation, but it will cause a anti-elevation. So it will not let the eye roll up. So that's why we call it an anti-elevation. So that's why it's a good procedure for DVDs. For a bilateral DVD with inferior oblique overaction, mind you, with inferior oblique overaction, you can do, and this is what we do. But if you want to weaken it 3+, 4+, what do? If you advance it more anteriorly, you will cause anti-elevation. So don't advance it anteriorly, bring it nasally and stay behind the inferior rectus insertion, and that will prevent anti-elevation. This is a severe inferior oblique overaction, and I hope this video you can run here. So this is inferior oblique anterior nasal transpositioning. 8 millimeters from insertion, a fornix incision is made, lateral rectus is hooked, and now you see the inferior oblique being hooked. It's important that we get all the fibers of inferior oblique in our hook and see the white triangle behind, so that we do not disrupt the inferior oblique fibers. And it is all in the sheath, no bleeding. You don't have to pass sutures before disinsertion. Separate the septum, intermuscular septum between LR and the inferior oblique, and disinsert the inferior oblique. And while you are disinserting, the posterior fibers are left a larger stump so that there is no damage to the macula by your scissors. And now you can hold this inferior oblique and pass sutures 60 vicryl. Now whatever you want to do, you can do a recession of Finks, Sparks, or as in this case inferior rectus is being hooked. The conjunctiva is now being unroofed from the inferior rectus. You come on the nasal side of the inferior rectus and intramuscular septum is separated. And bring the inferior oblique on the nasal side. Here you have to be careful that you also separate these the septum attachments so that the inferior oblique is now brought totally on the nasal side, and 2 millimeters nasal, 2 millimeters posterior to the nasal border of inferior rectus. These sutures are passed, both these sutures are being passed, so the inferior oblique is clumped here. If you spread the inferior oblique here, it will cause more of EZO, so it's better that you just keep it here. And now you can see the inferior oblique is totally nasalized. You can make it more and more nasal if you want more effect. So this is a very good procedure for 3+, 4+ overaction of inferior obliques, and no anti-elevation will be created if you do not advance it beyond the inferior rectus. Tame the wild obliques. I am again and again saying no to IOMyectomies, because you want a razor with an eraser. You want to do a surgery which can be undone or treated it differently by another surgeon. Don't make it difficult for another surgeon after a myectomy, because I have cases of second time coming after myectomy and I am at a loss what to do. So that is something which is the takeaway. And now we move on to the next speaker. I would invite Dr. Ankur Sinha. So we have Dr. Ankur from Jaipur going to tell us about the management of 6th and 4th nerve palsies. Is it there? आपने कहा था उधर भी कर दिया हमने. Okay. I think that's what. मेरा भी लैपटॉप है ना, वही कंफ्यूजन कर रहा था. वहाँ चलाओ तो देखें, इनको लगा इनका लगा. Hopefully this works here. TV Mac and it was not working from here. We checked it. I think. एक मिनट रुको. I think एक मिनट रुको. बेटा. टाइम शॉर्ट हो जाएगा ना फिर. चल गया.
Thank you, sir. Thank you for including me in the IC. Sir has always been a mentor and guide to us. So I'll be talking in brief about management of 6th and the 4th nerve palsy. So the signs and symptoms of 6th nerve palsy are horizontal diplopia, which is worsening towards the affected side. There's a face turn, and then the measured esotropia is more in the field of action of the paralyzed muscle. So this is a case of acute onset diplopia following trauma. So it's a case of acute traumatic 6th nerve palsy. All that is required in most of these cases is just observation and follow-up, because they tend to improve within a period of next 3 to 6 months. This is another case of 34-year-old male presenting with sudden onset double vision. He had mild headache on and off with occasional vomiting. There is no neurological illness otherwise, and there's mild abduction limitation we can see on both sides. So this looks like a bilateral 6th nerve paresis. On examination, the visual acuity is 6/24, anti-segment is absolutely fine, but this is what the fundus looks like. So there's a gross papilledema, and the neuroimaging reveals a large intracranial space occupying lesion. So whenever we have an acquired case of 6th nerve palsy, always do a dilated fundus evaluation and rule out papilledema. Now, management options in the acute phase would be occlusion, prisms, and Botox. But in the but definitive solution comes in the way of surgical once the stability of alignment is there. Surgical interventions for a case of partial sixth nerve palsy, the options would be MR recessions, LR resections, RNR procedures. RNR can be combined with the contralateral MR recessions. So this is a case of post-orbitotomy sixth nerve palsy. We can see a good scar here, and she landed up with sixth nerve palsy. All that is required here is an RNR procedure, and she improves pretty good with good alignment pre and post-op. Now, total the sixth nerve palsy has a problem, so we have to think in terms of different options like a partial VRT with MR weakening procedures, which could be a Botox or a recession, a full tendon VRT with MR weakening procedures, or a rectal muscle reunion procedure with MR weakening. So there are various procedures described in the book, like the Hammersheim, where there's a partial VRT of the temporal halves. O'Connor made it full tendon VRT with LR cinching. Carlson and Jampolsky advocated adjustable partial VRT. Then we had Jensen's muscle reunion procedures. They were all done to kind of minimize the injury to the blood vessels. Kushner modified to the middle halves, but there were always a problem of strangulation of vessels. So then comes this Nishida, Rosenbaum talked about full VRT with Botox, and Foster added the Foster's augmentation suture to augment the action of the transposed muscles. Then comes this Nishida's procedure, which is a newer entrant, and this initially it was described with the muscle split, and later the split was avoided. So what we do is we try to shift the muscle about 8 to 10 millimeters from the insertion and 10 to 12 millimeters radially midway between the lateral and the superior rectus, and lateral and the inferior rectus, and there's no splitting of muscles. So we can also add adjustable MR to make it adjustable and modifiable. So it's a case of left post-traumatic sixth nerve palsy. The patient undergoes large MR recession along with the VRT, half tendon VRT with the Foster's suture. And this is the pre and post alignment. So when we do such large surgeries, we do tend to have a little bit of lid anomalies, which are anticipated in these cases. Another case of sixth nerve palsy following a road traffic accident is diplopia in the primary gaze and face turn to the left. So the patient has a right post-traumatic sixth nerve palsy. The patient undergoes MR recession, which is adjustable along with the superior rectus transposition to the lateral rectus. So this is another case of post-viral sixth nerve palsy with diplopia in the primary gaze and face turn. She also goes a similar procedure, MR recession with superior rectus transposition to the lateral rectus. This is 5 weeks post-surgery. And Botox can also be added in the early phase to prevent the MR contracture and make the diplopia amenable or manageable by the patient for some time. Observation can be done in acute cases with no neurological signs, but these days it is important to advise a neurological evaluation even in the subtle changes, whatever we observe. For young adults, look for the risk factors. For adults, if they have vasculopathic factors, they tend to improve on their own with time. Now we move on to the fourth nerve palsy. Now this is one of the most common nerve palsies which is seen. It is usually congenital, post-traumatic, viral, and ischemic. They usually present with a head tilt, asthenopia, vertical strabismus, and a diplopia. And mind that this is never a sign of raised ICT. This is usually a sign of trauma. It may be associated with diabetes and hypertension, which can improve with due course of time. So we have the NAPS classification with respect to the right eye. This guides us which surgery to do in what kind of a particular patient. So the commonly seen as a right, this is with the right eye. So if there is a maximum abnormality in lever elevation, so plan for an inferior oblique recession. If there is maximum abnormality in the depression, that oblique tuck can also be done. So accordingly, they have been classified into 7 types, and the surgeries have been advocated according to that. Now, suspect a bilateral sixth nerve palsy with concussion injuries when there is a V pattern or a chin down posture, there is alternating hypertropia, there is an objective torsion of more than 10 degrees, and the patient complains of subjective torsion. So these are all features of a bilateral sixth nerve palsy, a bilateral fourth nerve palsy, which should be looked into. Now, management options for a congenital, again, plan for surgery. For acquired cases during the acute phase, you have to wait. Botox may not be a good option here because if you give it, it's going to create more problems even to the superior, inferior oblique and inferior rectus also can be involved with the Botox. 6 months later, you can plan for a definitive solution, which can be surgical. Now, Park's 3 steps test helps us identify the culprit of the muscle culprit in case of head turn. So whenever there is a elevation, like in this case, there is a left hypertropia, these 2 muscles are either underacting or these 2 muscles are overacting. So when this hypertropia increases in dextroversion, so we are left with the 2 muscles, that is the superior rectus of the right eye, which is overacting, or the superior oblique, which is underacting. And when we do the head tilt again here, this is in aggravating the hypertropia. So we are left only with the superior oblique of the left eye, which is underacting, and this is how the Park's 3-step test goes. So this is a case of 17-year-old male presenting with head tilt towards the right side since early childhood, and we can see that there is a elevation which increases in the dextroversion and with the left head tilt. So the elbow L over R increases. So it's a case of left inferior oblique overaction. Left surgery has been done for this patient. So this is the three-step test, forced surgery, and this is the torsion which is improved. A young boy with a SOP here, we can see there's a marked elevation, but the problem here is in the depression. So the patient undergoes tuck, and this is post-tuck. We have little bit of browns left, but the alignment improves. So in the end, I would just say careful assessment and proper choice of procedure is a key to success in paralytic strabismus, more so in the fourth and sixth nerve. Thank you.
Is the audio there? Yeah. So you covered it very nicely. If there is any one question, I mean, mostly we'll have the questions at the end. So you can keep jotting down your questions and send us. So we will have these questions answered at the end of the talks. So Dr. Ankur, thank you very much. So I think you have covered it so nicely. But just to refresh that we have a full plate for management of sixth nerve palsies, apart from the LR, MR recessions or the various types of augmentations you can do, and the modifications that we have, and the Foster sutures, the cross-section sutures, and the Nishida's procedure. So it's going to be, after some time, you'll get this plate on your food court. So we move on to the third nerve palsy. And this is another difficult subject that we usually come across, that how to manage. And third nerve, as you know, is a little more complicated nerve because it supplies so many muscles in the eye. Works differently. So how do you manage? Simple cases like this in which the eye is coming up to the midline, probably you can do a LR recession, MR resection, and that works very well as shown here. So third nerve palsies, first of all, analyze what is the picture. Ptosis is there or not, pupils are involved or not. For PGs particularly, don't miss out on the accommodation. If there is a young person, don't miss out that the near vision is also affected in the exams. You may be caught up for this. So you have to assess that in a person who is young. So look for that, and that will tell you what is the picture of third nerve that is you are dealing with. It may be ischemic, which is there pupil sparing in 70% of the cases. Mind you, all ischemic may not have pupil sparing. Some may have pupil involvement if they are more extensive ones. So do not rule out that. So whenever we have a partial or a incomplete third nerve palsy, wait for some time. Maybe in a 3 or 5 days time, follow up these cases to see if pupil is getting involved, and you may have to do an imaging in all these cases. Nowadays, we are veering towards more and more imaging for that. Regarding the management of ischemic third nerve palsies, as you know, if they are pupil sparing, you have to do special tests to find out what is the cause, and it may be just a simple blood pressure which is ill managed, sugar, lipid profile, homocysteine, ESR, CRPs, or specific investigations. So, and diabetes is getting more and more commoner, and it is involving the third nerve. Cases which have a problem like a headache and all, you also look for aneurysms which may be there, which may be the problem. So how do you manage? Complete ocular motor diagnosis. Natural recovery is allowed for cases in which you are not doing any neurological finding, or you have not got anything. If there is an ischemic problem, obviously you are going to treat it accordingly. If there is a neurologic problem, you will treat it. But otherwise, you are going to follow up 2-monthly basis for the recovery. If he is insistent, you can give Botox in the little rectus to expedite the recovery. Otherwise, you can wait for 6 months' time to manage. Now, this case, for example, he was a doctor. He has a large third nerve palsy with an exotropia, but the eye is fortunately coming up to the midline, although just touching. So what I did was LR recession of 24 millimeters. Larger recessions are required. Normal rules are for normal people. You have to have different rules for abnormal people. Like here, the little rectus is abnormal. So you have to do a larger recession. So don't be homeopathic in this. You may have to do 18 mm according to the FDT. They're as tight as it. You have to relieve the FDT fully. If you have not been able to relieve the FDT at the end of the surgery, your surgery is bound to fail. So be aware of this, and then you see that the eye rolls up very nicely. Even adduction is improved in such a situation. This is another case in which the eye doesn't come up to the midline. Now in these cases, when the LR is not very tight, you can shift the LR, nasal transposition of the Y split LR. The split LR nasally transposed, and this gives you the adduction from lateral rectus muscle. Although it is not going to be a very useful adduction because it is going to fire at the wrong time. But yes, it still makes the eye stay in the primary position. So this is also a possibility that we can do nowadays. Sometimes you can also work on the vertical muscles on the other side in order to improve the vertical actions. Like in this case, this girl, we had done the LR shifting to the MR, and also we have done the vertical rectus to correct the vertical deviations, which were also quite large. Now, where very tight LR, what do you do? So, in such cases, you have to do supramaximal recession, maybe 28 millimeters, but still if you find this is not going to work, you can do a periosteal fixation of the lateral rectus. It is the periosteal fixation of the lateral rectus to the lateral orbit. This was described by Velle's group, and we find it useful in very tight LRs that we can do. But cases which are still like 90 prisms, 100 prisms of exo, what do? You can fix the globe nasally. So finally, I mean, this is another thing which you can do, and anchor the globe to the nasal side, at least give him the diplopia-free position in the primary position. And this was described earlier with the DCR skin approach, and now whenever we do the precurricular approach, which is going to be without any skin incision. Now, cases which have an aberrant regeneration have to be handled differently. Some cases like this, there is an aberrant regeneration, you find that in the primary position, the eyes are ortho. Only the problem is with the lids. So we don't do any squint surgery in such cases. You have to advise them, counsel them that there is a problem. Even if you do a lid surgery, it can be a little problem that it may open up at the wrong time. So you have an aberrant regeneration in which there is an exotropia. You can take advantage of this, operate on the normal eye. Contralateral recession resections can be done, like in this case, in which the lateral rectus, as you can see, is having the ptosis, but it opens up when he looks to the dextro gaze, the right gaze. So what you plan to do is right eye, the normal eye, LR recession, MR resections. And as you can see here, the ptosis gets lifted up. So that is something which you can take advantage of. Sometimes there are partial third nerve palsies in which there is not a full picture. So here there is a picture in which inferior division was mainly involved. There was a depressor palsy which was there. So what we have done in this case was a modified inverse naps. So what do we mean by that? Here we have the lateral rectus reinserted at the right inferior rectus without any recession, because it's a tighter LR and we want it to work for the depression. But we mobilize its force totally to the inferior compartment, and we have resected the MR 6 millimeters and inserted it. So it corrects the exo by the MR resection, and the lateral rectus is going to add to the depression. And as you can see, her reading has also improved and the exo has also got corrected. Cases like this in which there is a residual third nerve palsy which has come from operated elsewhere, she was still having a residual exo, but there was a marked incompetence in the levo gaze. Now if you are operating on the other eye, you have to be careful that you correct this part. And here there is a handy procedure of lateral rectus Scott procedure. What is Scott procedure? This is the recession and resection on the same LR muscle. So this is something which will be very helpful, you can find, for cases which have incompetence in the lateral gazes or cases which have a divergence excess exotropia. Now this is a re-surgery. Sometimes we get cases which have been operated twice earlier and still they have problem. You need to explore, lateral rectus has been recessed again here 25 millimeters, 7 millimeter hangback with the inferior rectus belly transfer to the MR. So this is a modified Nishida in which I have used only the inferior rectus to have the effect, and this is working fine for him, he is pretty good. So important points to remember: deviation in primary position and other gazes. Fixing eye, you have to find out which is the eye which is having good vision, and that is the deviation you need to correct. Look for incompetence, realistic goals to be set and explained to the patient. Individualize the treatment. FDT for LR is very important in our procedure, and you have to do accordingly the split LR to MR or option of the contralateral muscle surgery. So if you can do a proper job, you may be a real squintellectual and give the vision, binocular vision to these patients. So now we have Dr. Ramesh Kekunia from LVP-I. Another complex problem which we have to deal with is congenital fibrosis of extraocular muscles, as you can see here. And Dr. Ramesh is going to handle this complex problem for us. He will tell you what are the important findings and the management. Dr. Ramesh.
Thank you so much. Thank you so much, Dr. Sharma, for this opportunity. Yes, I will be talking about congenital fibrosis of extraocular muscles. Can I have the show of hands who see more than 5 CFUMS per year? Less than 5? Okay. All of this, it's pretty rare. I see most of you are seeing less than 5, but some of you are not seeing also. That's why this is, strabismus is 1 to 4% of the population. I think the congenital fibrosis is total of 2% of the strabismus population. That's why it's pretty rare to see this kind of things. Sometimes you think the muscle can behave very differently. Some people can normally do this kind of tactics, and sometimes multiple things are affected. Abduction is affected, adduction, there is ptosis. Which muscle is really affected? There is some kind of aberrant innervation. And why, even if you are doing less than 5 surgeries or maybe once a year, it's important because most of these kids, it's a vision restoring surgery. It's not just a muscle alignment in terms of getting the eyes aligned. In terms of surgery, it's pretty complex. Whatever tightness, you try to release it. That's what we need to. And this comes under the typical CCDD. It's a early developmental incident, leads to specific disinnervation pattern so that they have this ophthalmoplegia. Problem is not there in the muscle, problem is there in the whole. It's not even the whole muscle, it's some of the connections there. They help to move the muscles, and during birth it does not happen. It can involve oculomotor system. Either there can be miswiring like this, or there is no wire at all. Because of this, you develop this problem. And in a short way, this is what really happens in some of the CCDDs. And these are the genes involved in the form of microtubule function. That's where they get involved. Third nerve and the fourth nerve is the most commonly involved nerves in CFUMS. In sixth nerve palsy, Duane is there, but when it comes to CFUMS, it's a combination of fourth and sixth nerve palsy. Imaging is important because we can go up till the level of innervation of each of this muscle, and you can see. And these are some of the other rare things what you can have. And this is what, in short, what you can have with result with this. Just always remember lid motility and pupil. This is important when you do a third nerve palsy or congenital fibrosis. If you give importance to this, then you can differentiate whether it is type 1, type 2, type 3. I will also add two more things. One is the imaging and then the genetics. If you do 3 of this with the comprehensive evaluation, you are doing justice to this congenital fibrosis of extraocular muscles. Then you can come to this kind of classification. All of you know there is type 1, type 2, type 3. There are very rare variants of type 4 and type 5. Ptosis is prominent, usually bilateral, except in type 3. Primary deviation is usually hypotropic in the type 1, again because of the nerve which is involved. And type 2 is usually exotropic. There is no hard and fast rule like that this has to be the only thing. They can have a combination of things. One important thing you need to remember is type 2 can have retinal problem and type 3 can have neurological problem you can have. And this is a very typical with the family. You can see type 1 typically bilateral, symmetrical it is, and usually it is hypotropic eye. Eye does not even go beyond the eye. You know the nerve involved in this cases. What do you do here? There is a large exotropia, there is a large hypotropia. You have to get this exotropia corrected. Along with, you also have to. Generally, lateral excess periosteal fixation with the large inferior rectus with nasalization works in most of the patient. But one rule in CFUMS is get the eye into esotropia on the table. Then your result in the long term will be much better. You can always use the imaging system to diagnose. You can see because of the misinnervation, look at the size of the muscles. All size in the sense here the third nerve is supplied, superior oblique is normal, superior oblique can be overacting. Sometimes if there is a large hypertropia, you need to do a superior oblique tenotomy, complete tenotomy as well in these patients. And this is typically type 2. They can have pupillary abnormalities. Look at the pupil. If they have some abnormality, it's type 2 most of the times. And they have a very large supralarge exotropia in this patient. Type 3 is very rare, but you need to carefully look at some kind of neurological. Just wanted to show this case, probably a type 2 or type 3 mixture here. She has esotropia with ptosis, and this is her extraocular motility. You can see bilateral abduction limitation and also elevation. It's a combination. You can't put it. And we sent for genetic evaluation also. She had KIF2A mutation here, and what we did here is a large bilateral medial rectus recession with inferior rectus recession. You can see post-operatively she is much better. How do you determine? There is no dosage. You can say that 50 PDET, do a 6 millimeter. It doesn't work. You have to do the surgery based on the tightness which is intraoperatively. It gave a fair correction in terms of alignment, but not complete. You can still see some abnormal head posture and a mild deviation. Again, one more case. You want on the table the patient to be exotropic, then you will have this long-term outcome. And always remember, they can have a muscle abnormality. They can even have a extra bands in this kind of patient. I just want to conclude with this slide. Always remember LMP, but when it comes to CFUMS, use imaging as well as genetic, because this will give you a complete understanding not only of CFUMS, the spectrum of disease associated with it. Thank you so much.
It was wonderful. As I said, CFUM is a complex problem. Fortunately, it is rare. So I think we have to be aware of this. These are CCDDs, as he had mentioned. What are CCDDs? CCDDs, anybody? What is the full form of CCDD? Any of the young people? Congenital cranial disinnervation disorders. And one of has been covered by Dr. Ramesh. The other one is Duane's retraction syndrome, which is much, much commoner seen. And the problem that we'll talk about is that. Duane's retraction syndrome, as you all know, is a common thing. It's what described by Hugh and all. But basically, it is going to be unilateral in 80% of cases and predominantly left side and more commoner in females. Now, this is an interesting thing which has been now answered by some clinical studies. Innervation in different DRS cases is going to describe it in type 1, 2 and 3. And Huber did a great work initially by electrophysiology, and accordingly we have classified them. But primarily what we now know is CCDD is a primary disinnervation and there is a secondary disinnervation. Most of the CCDDs, there is a lag of innervation first of all in the embryological phase, and then there is a secondary aberrant innervation, which is why there are going to be abnormal synkinesis, abnormal aberrant innervations. In Duane's is one of the classical examples when there is a co-contraction at the paradoxic time. So you see that the lateral rectus does not fire during abduction, but fires during adduction. And this is true for all the types, whether it's type 1, 2 or 3, but it is only the lateral rectus innervation which is different in these three types. So in the clinically, when we talk about ESO-DRS, how do we see? Esotropia in primary position, there is a lack of abduction, and there is in adduction you find there is a retraction narrowing of the palpebral aperture, and also upshoots and downshoots. So whenever you see upshoots and downshoots, think of Duane's retraction syndrome. Whenever you have an upshoot, also look for downshoot to differentiate an inferior oblique overaction. Okay, so and you will find that once there is this triad of narrowing of palpebral aperture, retraction, and upshoot downshoots, it has to be a Duane's retraction syndrome. In the primary position, it's ESO, so we'll call it ESO DRS. And this is a picture of exo DRS. Now here the primary position is exo. There is a limitation of abduction still in this, and on narrowing, retraction and upshoot and downshoot is still there. So it's a exo DRS. So if you do the studies, you will find there is a missing sixth nerve. Like CFUM is primarily third nerve abnormality with some add-ons. Here it's the sixth nerve abnormality along with Mobius, which is also a sixth nerve problem which is causing that. So the paradoxic innervation is the basic problem, that lateral rectus is firing at the wrong time. So here the culprit or the problem is lateral rectus. Victim is medial rectus. Many a time we are troubling the medial rectus also unnecessarily. Like in exo DRS, wrongly in past people have been weakening the medial rectus also. It's like the police comes and finds there is a fight going on. It puts both of the people inside, not finding out who was beaten and who is the beater. So you have to be careful about that. So we have different associations. These you can see in the detail what ocular associations are there and what are the systemic associations which are described along with. And the syndromes, particularly for PGs, keep in mind that you may have golden Haar Klippel, Field, Wilder-Wang, Holt-Oram, Okahiro, DRRS or IVIC syndromes. So we'll, in short, I'll just come to this slide, which is an important study implicating thromboembolism and the problem of thrombogenic influences. And here malnutrition, dehydration, alcohol, infections and all these things in the first trimester have been blamed. The Duane's retraction syndrome is occurring in the 6 to 8 weeks of embryogenesis, something going wrong which is causing it. And if we can control this, probably we can reduce the incidences of Duane's retraction syndrome in future. Thalidomide and misoprostol have been blamed by some people. Genetics studies are going to be the future for most of the CCDDs. Right now in India, we do not have that option easily available. Management, how do we do? So we have these plans. First of all, look for ESO, EXO or ortho. Accordingly, you will change your management. Look for, is there any significant co-contraction? Co-contraction as a rule is always there in DRS. Is it significant or not, that you have to find out. Thirdly, how much is the LR activity? Is it there, normal, or is it not there at all? Like in ESO DRS, there may not be any LR activity. In EXO, there may be some LR activity or it may be full normal. And force reduction test intraoperatively for both MR and LR. Now, this case as an example, FDT for MR is positive and minimal co-contraction is there in the left eye, you see here. So what we do in such a case? Just an MR recession of one muscle that corrects the primary position, reduces the problem of the here. But if there is a significant co-contraction, you cannot just do an MR recession. In ESO DRS also, you have to do an LR recession with Y split. So this is very important. Otherwise, you will create a synergistic divergence. So in such cases, you have to match the recession of medial rectus, which you require to do as per the tightness of the MR, and match it with the LR recession with Y split. Some people have advocated doing resections. I do not usually say that we should do that. So I do not really recommend doing that. But ESO DRS cases, SRT can be done in some cases in which the co-contraction is not much. So there is a planning algorithm which is published in IGO in an article. You can go through that. How much is the deviation, how much is the ESO, and how much is the tightness of MR, you can handle it. Coming to EXO DRS cases, what are the options? You can do a Y splitting of LR, large 12 to 18 millimeter LR recession, periosteal fixation of LR, or total extirpation, which I wouldn't recommend, but some people have done. How much? How do you decide? XT, how much is the exotropy in primary position? How much is the co-contraction? How much is the normal LR activity? If there is some LR activity, don't do a periosteal fixation or a drastic procedure on the LR. You want to retain some abduction. So just weaken it, but significantly. So in this case, for example, we did a LR recession with a Y split. Now here the exo is there, abduction is there. So you don't want to lose this abduction. You do an LR recession 12 mm with a 21 millimeter split of the two ends of the lateral rectus, and this does the job. If time permits, we'll also have the video. But right now, little is no good for exo-DRS. Small amounts of recessions are not good. It's like, as I said, a terrorist. If you just fine him little bit and leave him, he will do the same mistake again. So you have to either put him in confinement or weaken him very significantly. This is a bilateral exo-DRS, and this is a periosteal fixation done because the abduction was poor. So in such a case, you can do a periosteal fixation. Cases in which there is a periosteal fixation done, in order to improve the abduction, you may do various things like partial VRT or a SRT or an IRT, or nowadays the modified Nishida procedure. Now this individual, we did that, and we find that after the surgery, there is good movements which have been retained. So nowadays we are doing modified Nishida procedure in order to improve abduction. So here this is a case in which we can improve the abduction, as you can see here, in spite of taking care of the lateral rectus nicely. Now this is the algorithm for the exo-DRS. Coming to ortho-DRS, finally, how do we manage? Now these eyes are ortho in primary position. So you have the challenge to retain the ortho and still correct the problem which is occurring in adduction. So here what we will suggest is do a adjustable procedure as far as possible, so that you do not compromise the primary position ortho. So this is to conclude in ESO, EXO and ortho DRS. Primary thing is find out the paradoxic LR activity and correct it. So now we have another complex problem, and that is Brown syndrome, and that's my colleague from AIIMS, Dr. Rohit Saxena, Professor Rohit Saxena, who is going to talk about the Brown syndrome management. Dr. Rohit.
Thank you, sir. Thank you very much for the opportunity to be here and present in your IC. It's always a pleasure. It's always a learning experience just listening to you. So I'll be talking about Brown syndrome. Essentially, well described, was initially called pseudoparesis of the inferior oblique because the primary problem is the inability of the eye to elevate in adduction, and also a superior oblique tendon sheath syndrome because it is the absence of the tendon sheath to lengthen, which does not allow the inability of the eye to elevate in adducted in primary position. It's not a very common, but again not so uncommon also as compared to some of the conditions we've been talking about. Just to demonstrate the condition, this is a patient of a right Brown syndrome. You can see essentially aligned in primary position. There is a small dip when the eye goes into levoversion, and the eye is unable to elevate, adduct and elevate. And normally you would have thought that this is either, if so it was an inferior oblique palsy here, you would have a corresponding superior oblique overaction, which is not a consistent finding. Some may have it, but often they do not. And accordingly, you would have expected that because the IO is underacting, the corresponding SO may be overacting, you should have an A pattern, actually has a V or a Y pattern. So the eye is going up, but suddenly it just switches outwards because it can't go up straight. So this is the classical feature. So there will be a downshoot in adduction, there is a deficiency in elevation and adduction, there is a limitation of the elevation in primary elevation, but there is no significant elevation deficit in abduction. There is a V or a Y pattern that is there, and the forced duction test is positive. So again, just to demonstrate that, you can see the limitation of elevation here, not so much and virtually aligned in this case, and the divergence in up gaze or a V or a Y pattern. Sometimes, as I mentioned, you may have a superior oblique overaction also present in these conditions, and you'll see the torsion, corresponding torsion in the fundus. It can be congenital or acquired. So most common is a short anterior part of the tendon sheath. It's an inelastic tendon, and also there are tendon trochlear complex problems where the telescoping of the superior oblique as it goes through the trochlea does not happen. So there are congenital additions in the entrance to the trochlea. Of course, there can be any other cause. In an acquired case, there could be inflammation, trauma, the Nine-Tooth syndrome, or iatrogenic, like we can do it, excessive tucking in case of a superior oblique palsy. So when you do an excessive tuck, that's what you're doing. You've tightened the superior oblique so much that it is not able to now relax enough to allow the eye to go up and in when the superior oblique is actually wrapping around the globe and requires its entire length. So it could be mild when essentially there is a restricted elevation in adduction. Along with that, if there is a downshoot in adduction, it becomes a moderate. Along with hypotropia in primary position becomes severe. So depending upon how severe it is, it becomes your indications for surgery. And brown plus would be an associated superior oblique overaction. Your differential diagnosis could be an inferior oblique palsy, but the difference would be an A pattern, as I mentioned, and a downshoot on the opposite side head tilt. A superior